Hi everyone. I know it's the end of the day, but I'll be trying to concise. Most of the information that I put here in the beginning have been presented by prior speakers, so I'll go fast through them. I'll try to be very concise and practical on what to do when you have abnormal pap test. So the objective is the importance of the cervical screening, cancer screening, the modality of screening that is available, advantages and disadvantages of each modality, the interpretation of cytological abnormalities, and the management of abnormal result. So the cervical cancer is the, which one is this? So it's the fourth most common cancer affecting women worldwide. Around 500 cases were estimated in 2012, and 85%, again emphasis, were in the developing countries, and half of those patients died from this disease, and 71% of all cancer deaths is related from cervical cancer, and again 87% of those are in the developing countries. The cervical cancer etiology is the human papillomavirus, and a fact is that it is the most common sexually transmitted disease with 79% estimated lifetime risk of cervical infection. HPV DNA detected in 99.7% of cervical carcinomas. HPV, as mentioned priorly, is classified into, based on their oncogenic characteristic, into high risk type oncogenic and low risk. The high risk is the most commonly 16 and 18, which account for 73% of cervical cancer. The rest account for the remaining cases. So this is the pathophysiology. The base of the cells at the epithelium get infected, virus get inside. They start to proliferate. I'm not going to go through the whole mechanism, but the process starts gradually to proliferate until you get grade 1, then grade 2, until you get grade 3, and eventually you have invasive cancer. Very important information that 90% of these infections are cleared within 2 years. Only 10% of those persist, and by the end of the 10 to 13 years, if they not get treated, they will develop invasive cancers. So screening for cervical cancers, we do have the pap test. There is the conventional and the liquid-based cytology, and there is the HPV. It could be used as a primary, reflex, and co-testing. Reflex meaning that if you have an abnormal pap test as ASCUS, then you would do an HPV test. Sorry, that's the reflex. The co-testing meaning you do it together, the pap and the HPV. So since the introduction of the pap test as a screening method, there has been a 70% decrease in the incidence and mortality from cervical cancer. So what's the difference between conventional and liquid? Conventional appeared in the 40s of the past century, and the liquid in the early 90s of the past century. Both have similar sensitivity and specificity for the detection of high-grade and low-grade intraepithelial lesions. Conventional pap smear is more specific than liquid-based cytology for ASCUS. The advantage of liquid-based cytology, it just reduces unsatisfactory pap test in subgroup of patients with obscure blood and inflammatory cells. The other advantage also is that you can offer them performing a reflex test, HPV. Overall, the sensitivity of pap test ranges between 50 and 70%. Reasons for failure is failure to screen, failure to detect abnormality in the first pap test, or failure to follow up abnormal pap test. So this is how it's been reported. This is the Bethesda system in 2001, and it's being currently used. There are 4 categories: the specimen adequacy, the general categorization, the interpretation of the result, and then educational and or automated other ancillary tests. Specimen adequacy, whether it's satisfactory or unsatisfactory. The satisfactory for the liquid base, there must be at least 5,000 cells. For the conventional one, there must be at least minimum of 8,000 cells. Generally, whether there is a negative for epithelial malignancy or there is abnormalities. The abnormalities are divided into, the first one is here, epithelial abnormalities. Where there is a squamous cells division and there is a glandular cell. The squamous cells, there is 4 categories: atypical squamous cells of undetermined significance, or cannot exclude high-grade lesions. Then followed by the low-grade squamous intraepithelial lesions, which represent CIN1 or human papillomavirus, multidysplasia, or cervical intraepithelial 1. Then there is a high-grade, which is the HSIL, that encompasses CIN2, CIN3, and carcinoma in situ. The last one, you can have also cervical squamous cell carcinoma detected by the pap test. The glandular, there's 3 categories: atypical glandular cell, and the atypical glandular cell favor neoplasia, adenocarcinoma in situ, or adenocarcinoma. I'll go through them later on also. So recently, the last system only have modified the CIN terminology. So they actually group the CIN2 and CIN3 together into one category, and they name it as high-grade intraepithelial lesions. To identify CIN2 as a high-grade lesion, there has to be a P16 staining. So the pathologist stain them. So of those who have a CIN2 with a P16 positive, which is the marker for activity for HPV, they will be noted as high-grade cell lesion, and those who are negative, they will regard them as a low-grade lesions. So what about HPV tests? So high-risk HPV tests, and I'm emphasizing in high risk, so it's not all HPV, it's only high-risk HPV test versus pap test. So the primary high-risk HPV, or in combination with cytology, is more sensitive than the pap test in the detection of high-grade lesions and invasive cancer. The recently published trial after long-term follow-up, the use of it high-risk alone or in combination with cytology reduced the incidence of high-grade lesions by almost 70%, alone or in co-texting, and reduced the incidence of cervical cancer by almost 50% compared to pap test. This also has an advantage of improved detection of adenocarcinoma in situ compared to the pap test. Role of genotyping. So trials looked at if there is a difference between different genotypes in the induction of cervical cancers and high-grade lesions. So they found that HPV 16 and 18, they have a cumulative incidence of high-grade over 3 years of 21 to 26% compared to other types, which is only 5 to 6.5%. So this is there are many guidelines, but they're all the same almost, just only with a slight difference in between the others. So I'm using here the ASSP guidelines from 2012. So all women who are under the age of 21 should not be screened. Simply the incidence of cervical cancer in that group is extremely low, and you would do more harm to detect one cancer. So they divided the group then the 21 to 29. These are should be managed with the cytology alone every 3 years. And then the group from the 30 to 65, there are 2 options for them. Either you do a cytology every 3 years or HPV co-testing every 5 years. If you include HPV with the cytology, should not repeat any, and if they're negative, should not be repeated before 5 years. More than 65, they don't need screening unless there is inadequate screening or a history of CIN2 or 3 or cervical cancer. Following restrictive for benign disease, they don't need any pap test. If there is a history of CIN2, CIN3 or cervical cancer, then they should be continuously having pap test. So recently updated guidelines, which is published almost 6 months. This is an article, it's 2 months ago, that have looked up the use of primary HPV screening versus pap test or versus co-texting, and they found that actually HPV screening primary reduced the incidence of CIN2, CIN3 and invasive cancer after a follow-up of 6 years. So these are now updated, and I think also the Saudi group published their guidelines, which include as a primary screening is HPV. They here include actually, however, the genotyping. I'm not sure whether adding this would make a difference a lot. It probably would add more cost. And especially in developed countries where there is no such facility to have these tests performed. So I think it should be followed by cytology afterward. If your cytology is negative, then this patient can be rescreened again to routine screening. Those who are positive, then they should go for colposcopy. So the first one is unsatisfactory. So what if you get an unsatisfactory? Unsatisfactory pap test, meaning that the specimen was not labeled well, or you have cells less than 8,000 per slide for the conventional one, or less than 5,000 in the cytology one. So scant celerity or obscured by blood inflammatory cells. So this pap test should be repeated in 2 to 4 months. Or you can offer them actually HPV testing. So those who are negative, it can be repeated back again as a routine screening in 3 years. Those who are positive, you can send them for colposcopy, or you can offer them genotyping if we have it. But I don't think it's available at every center here. Those with HPV 16 and 18, they can go for colposcopy. Other tests, they can go and have a pap test. And if they are abnormal, they go for colposcopy. If normal, they go back again to routine screen. What about if you have negative intraepithelial lesion or malignancy, but you have an absence of the transformation zone and epithelial cells? Offer them HPV if it's not done. If it's positive, you could do a cytology and HPV at 1 year, and based on that result, then you if both are negative, then they don't need to they go back again to routine screening. If one of them is positive, then they go to for colposcopy. If it is negative, then they go back again to a routine screening. What about ASCAS, which is atypical squamous cell of dermal significance? This is the most common abnormality, which represents 2.8%. The risk associated with ASCAS is actually being found 7% on the underlying CAN2, 3% underlying CAN3, and only 0.1% underlying invasive cancer. So it's most of the time it's a benign thing. 25% of those are associated with HPV, and if you subcategorizing them based on positivity of HPV, those who is HPV positive are 80% there is underlying CAN2, 7% underlying CAN3, and 0.4% only underlying invasive cancer. Those with negative HPV, there is only 1.5% risk underlying of high-grade lesions. So what's the options? The options is you could offer them to repeat pap tests in 1 year. If it's ASCAS or more, you refer them to colposcopy. If it's normal, they come back again to routine screening. The second option is to do a reflex test. This is a large trial which is called the Atlas trial. So those patients who had positive HPV, they go for colposcopy immediately. Those who is negative for HPV, they go back again to routine screening. What about atypical squamous cells cannot exclude high-grade lesions? The incidence is 0.17%. Risk, there is CIN2 underlying 35%. CIN3 is approximately 18%. The risk of invasive cancer underlying is 2.6%. The patient must be referred for colposcopy. Do not perform HPV, as most of these patients actually are positive, so it's not going to change anything in your management. Low grade, the squamous intraepithelial lesions, so the incidence is approximately 1%. Risk of CIN2 underlying that lesion is 16%, CIN3 approximately 5.2%, and invasive cancer is 0.16%. HPV is positive in 88%. Those who was actually HPV positive, the incidence of CIN2 is 19%, and CIN3 is 6%. Those with a negative HPV, actually the incidence of CIN2 is 5 and CIN3 is 2. So there are two options. So you can either refer them directly to the colposcopy, or you can do an HPV test. HPV test positive, you can send them to colposcopy. Negative, you can repeat both tests in 1 year. And the rationale behind that is because 90% of women, they actually will clear that infection. If any abnormal result, come back in 1 year, they go back again to colposcopy. Otherwise, if it's normal, they go back again to a normal routine screening. High-grade lesions, so the incidence is 0.21%. The risk underlying CAN2 is 70%, CAN3 is 47%, and invasive cancer is 7%. Again, 75% of those patients are HPV positive. Even those with negative tests, the risk of CAN2 and 3 is more than 50%, and invasive cancer is 6%. So they have to be referred to colposcopy. The last category is the atypical glandular cells. So the incidence is 0.1 to 2%, and it varies based on the age that you're examining. The atypical glandular cells can be endocervical, endometrial, or not otherwise specified. There's a risk of 10% of endometrial CA. Those who would favor neoplasia could be endocervical, and the risk underlying of adenocarcinoma is 5%. Adenocarcinoma in situ is 2.5%. If it's endometrial, there's underlying risk of 27% endometrial CA. Complex atypical hyperplasia is 22%. The other is adenocarcinoma in situ, which is also there's a risk of around 30% underlying invasive cancer, or it could be reported as adenocarcinoma. Keep in mind that 60 to 70% with reported adenocarcinoma, atypical glandular cells, the findings are benign. Also, another thing that to keep in your mind is that 50% are associated with a squamous abnormality. So what to do if you have an atypical glandular cell? So if you have an atypical glandular cells and it's specified as endometrial, you have to do an endometrial biopsy and endocervical curettage. If they are negative, they have to be referred to colposcopy. Other categories, they have to be referred to colposcopy, and you do an ECC, and to perform an endometrial biopsy if the age is above 35 and at risk of endometrial CA. Those who have been reported as adenocarcinoma in situ, they have to be referred for colposcopy. If no lesions are identified, cold knife biopsy has to be performed. And I think that's it for me.